This episode is proudly sponsored by the Buffy Coat's elusive layer. Watch in awe as blood, under immense G-forces, performs its magical separation trick, leaving a pristine, almost invisible, thin white band between the red cells and plasma. This is where all the important cells are supposedly hiding, compelling us to extract them with the precision of a diamond cutter, hoping to find that single, diagnostically relevant cell that justifies the entire elaborate charade. Sometimes it's there. Mostly, it's not.
Okay, let's unpack this. Welcome to the deep dive. We're here to, put on our investigative hats, sift through some pretty complex medical info, and pull out the absolute gold for you. Today we're navigating the tricky world of normocytic anemias. We're really zeroing in on the hypoproliferative forms. And this is especially for you, our incredible medical laboratory scientist listeners. You're the ones making sense of blood work day in and day out, maybe prepping for a big diagnostic call, or maybe you're just, super curious. Our mission, to arm you with the sharpest insights into the pathophysiology and the critical lab testing, all based on the sources we've dug into. So when we talk anemias, cell size is a key starting point, and today it's all about normal mean corpuscular volume, the MCV, normocytic anemias. But that's really just scratching the surface, isn't it?
That's absolutely right. It's fascinating, actually. Normal cell size gives us, like, a starting block. But the reticulocyte count, that quickly becomes our crucial guidepost. See, a high count points towards increased destruction or maybe blood loss. The bone marrow is responding, it's churning out cells. But a low reticulocyte count, especially when someone is anemic, that immediately points the finger at the bone marrow's ability to actually produce red blood cells. That's the real hallmark of these hypoproliferative anemias. It tells us the factory, the bone marrow, it just isn't ramping up like it should, even though the body needs it to. Sets the stage, really.
Okay, so the factory analogy works well. If the bone marrow's the RBC factory, a low retic count means it's slacking off. We're talking about anemias where the factory just isn't pulling its weight, like producing fewer red blood cells than needed. And it's not usually about lacking raw materials like iron, but a problem with the production line itself.
Precisely. The core feature is reduced erythropoiesis. That's just the fancy term for red blood cell production happening right there in the bone marrow. And this brings up a really important question for us in the lab. If the factory is the issue, how do we, check its status? Often, a bone marrow aspiration and biopsy becomes essential. It's really the only way to get direct information about the cellularity, how packed the marrow is, and the maturation stages of the cells. It's like getting eyes directly on the factory floor. But of course, before jumping to that, it's absolutely critical to rule out other things first. Active bleeding, hemolysis, where cells are being destroyed too fast, or maybe key nutritional deficiencies. Once those are off the table, then we tend to categorize the causes. Is it a primary bone marrow disorder, something wrong inside the factory, or is it secondary external factors messing with production?
Right. Okay. So once we've confirmed the factory, the bone marrow isn't keeping up, our detective work zeroes in on the why. Is it intrinsic problem, or are outside forces putting the brakes on? Let's start by looking inside the factory itself, those primary bone marrow disorders. First one up, aplastic anemia. Sounds pretty serious. What's happening cellularly here?
Aplastic anemia. Yeah, it's essentially bone marrow failure. Full stop. It's characterized by pancytopenia. That means a significant drop across all three major blood cell lines, red cells, white cells, and platelets. And this happens alongside a markedly hypocellular bone marrow, meaning the marrow itself is quite empty. The underlying issue, the pathophysiology, is damage to or destruction of the hematopoietic stem cells, the HSCs, in the marrow. These are the master cells, the ones that generate all the blood cell lines. So if they're knocked out, the whole production shuts down. Clinically, you see the results. Anemia causes fatigue, low platelets, thrombocytopenia lead to bleeding, and low neutrophils, neutropenia, makes patients highly susceptible to infections. For you, the MLS, the CBC is going to scream pancytopenia. Low hemoglobin, hematocrit, RBCs, WBCs, platelets, all down. On the peripheral blood smear, you'll typically see normocytic, normochromic red cells, but the key is often the absence of weird-looking cells you might see elsewhere. And like we said, the reticulocyte count very low, often practically zero. That's a huge clue. Then the bone marrow exam confirms it. Hypocellular marrow, very few hematopoietic cells left. Sometimes flow cytometry can even show fewer or abnormal stem cells.
Wow, okay. That pancytopenia plus the hypocellular marrow paints a stark picture. Yeah, a factory shutdown. But thinking from the bench perspective, when those initial CBC results pop up, are there any really early, maybe subtle clues that might make you lean towards AA versus, say, a really bad infection or maybe even some rare nutritional issues that might look similar at first glance? Any lookalikes we need to be super careful about before that definitive bone marrow result comes back?
That's a really vital question. Severe infections, yeah, they can cause cytopenias, but usually you see a strong inflammatory reaction, maybe toxic changes in the white cells, things you wouldn't typically see in pure AA. And nutritional deficiencies like really severe B12 or folate deficiency, they usually cause macrocytic anemia, big red cells, not the normal cytic pancytopenia of AA. And they tend to respond if you give the missing nutrient. I think the key differentiator for an MLS looking at AA is the consistency of that pancytopenia across all the lines without an obvious trigger like a raging infection or maybe clear nutritional deficit signs. And that profoundly low red tit count, it's often way lower than you'd expect even with other types of severe anemia. That's a massive red flag. It's the sort of silence of the marrow that's really telling, not just the low numbers themselves.
Okay, that makes sense. The profound quietness. So AA is the factory shutdown. But what if the factory isn't shut down, but it's trying to make stuff, but the products are all coming out wrong, faulty? That sounds like it brings us to myelodysplastic syndromes, right? Which always seem incredibly complex.
Oh, MDS. Yeah, they are truly complex. These are clonal hematopoietic stem cell disorders. The key phrase here is ineffective hematopoiesis. What that means is the bone marrow is often busy, sometimes even hypercellular. It's trying to make cells, but they don't mature properly or they don't function right. It's like that factory producing defective goods. And importantly, these syndromes carry a variable risk of eventually progressing to acute myeloid leukemia, AML. Pathophysiologically, you have dysplastic, meaning abnormal development, in one or more of the myeloid cell lines. That's your red cells, your white cells, your platelets. This faulty development leads to cytopenias, similar in outcome to AA sometimes. But the reason is this underlying dysplasia. That's the signature. Clinically, again, you see anemia, thrombocytopenia, neutropenia, similar symptoms. But for the lab, while the CBC shows cytopenias, the peripheral blood smear is where your sharp eyes become absolutely critical. You'll often spot distinct dysplastic features. In red cells, look for things like oval macrocytes, maybe some hypochromia, basophilic stippling, those little blue dots inside the RBCs. For neutrophils, keep an eye out for the pseudo-Pelger-Huet anomaly, that weird bilobed nucleus that looks like old-fashioned glasses instead of properly segmented, or hypogranulation, where they lack their normal granules. Platelets might look unusually large or have strange granulation. The retic count, it'll be low or maybe even normal, but crucially, it's inappropriately low for how anemic the patient is. It shows the marrow isn't responding effectively. The bone marrow exam itself might be hypercellular or sometimes hypocellular, but the defining feature is dysplasia in one or more cell lines. And, very importantly, cytogenetic analysis, looking at the chromosomes, often reveals specific abnormalities, like a deletion of part of chromosome 5q or an extra chromosome 8, which really helps classify MDS and predict prognosis.
You described those dysplastic features really clearly, thanks. To make it even more concrete for everyone listening, could you give a quick scenario like we're spotting just one of those specific things on the smear, maybe that pseudo-Pelger-Huet thing, immediately shifts the diagnostic gears even before you get the bone marrow results?
Absolutely. Let's say a patient presents with fatigue, maybe some recurrent infections, anemia, and a low white count on the initial CBC. Just generalized cytopenias, right? But then you're doing the manual differential count and you notice, hey, a good chunk of these neutrophils have that really striking bilobed pince-nez nucleus, the pseudo-Pelger-Huet anomaly. That's not normal at all, and it immediately screams, think MDS, even if other features aren't super obvious yet. That single finding prompts the clinician to order the bone marrow biopsy and the cytogenetics much sooner, much more urgently than they might have otherwise. It's often those seemingly small details on the smear that really guide the whole workup.
Got it. The smear details are crucial. Okay, so from pancytopenia in AA and faulty production in MDS, now let's consider a really targeted attack, a highly selective strike just against the red cells. What defines pure red cell aplasia?
Pure red cell aplasia, or PRCA, is fascinating because it's so specific. It involves the selective destruction or suppression of just the erythroid precursors in the bone marrow. The red cell assembly line is shut down, but everything else is working fine. This leads to severe anemia, but with a marked decrease in reticulocytes, often near zero because the red cell precursors are gone. The causes, the etiology, can be acquired, maybe autoimmune, where the body's own immune system attacks those precursors, sometimes specific infections like parvovirus B19, which has a nasty habit of directly infecting and killing erythroid precursors. Certain drugs can trigger it too, or it can be associated with a thymoma, a tumor of the thymus gland. There are also inherited forms like diamond-black fan anemia, but the acquired forms are more common in adults. Pathophysiologically, it's usually either autoantibodies or cytotoxic T cells specifically targeting and wiping out those early red cell precursors, the CFUEs and proerythroblasts, so they never get a chance to mature. Clinically, the big thing is severe anemia symptoms, but critically, there's an absence of other cytopenias. White counts are normal, platelet counts are normal, it's just the red cells. In the lab, CBC shows severe anemia, normal white BC, normal platelets. The peripheral blood smear usually shows normocytic, normochromic red cells, nothing particularly abnormal there, but the Reddit count, as I said, very low, near zero usually. And the bone marrow exam is key. It shows normal overall cellularity, but a marked decrease or even complete absence of the erythroid precursors, just gone. Sometimes specific tests can help pinpoint the cause, like antibody testing for antibodies against erythroid precursors or EPO, or a PCR test for parvovirus B19.
That specificity is really striking. Normal white BC, normal platelets, just profound anemia and no retics. Okay, so we've looked at problems within the bone marrow factory itself, but it's just as vital, like you said earlier, to remember that sometimes the factory is fine internally, but external factors are gumming up the works. This brings us to those secondary causes. For our listener in the lab, what would you say is the single most common trap or point of confusion when trying to sort out these secondary causes from the primary bone marrow disorders? And how can the lab data help avoid that trap?
That is an excellent point. I'd say the most common pitfall, especially at the bench, is potentially confusing anemia of chronic disease or inflammation, sometimes called ACD/AI, with straightforward iron deficiency. Both can sometimes present with normocytic or even slightly microcytic anemia, but their underlying reasons are totally different, and crucially, their iron studies look different. In ACD/AI, chronic inflammation boosts the production of a hormone called hepcidin. Hepcidin basically acts like a gatekeeper, trapping iron inside macrophages and gut cells, making it unavailable for making red blood cells. So in the lab, you'll typically see low serum iron, yes, but normal or even high ferritin levels because the body has iron stores, it just can't access them properly. And the total iron binding capacity, or TIBC, is usually low or normal. In true iron deficiency, though, ferritin, the storage iron, would be low and TIBC would be high, reflecting empty stores and the body trying hard to grab more iron. Nailing those iron studies is absolutely crucial to tell them apart. Beyond that common one, other secondary causes to keep in mind, definitely chronic kidney disease, CKD. The kidneys, remember, make most of the body's erythropoietin, EPO, the hormone that tells the marrow to make red cells. So in CKD, EPO levels drop, plus uremic toxins that build up can also directly suppress the marrow. So here, you might find EPO levels that are inappropriately low for how anemic the patient is. Then there are certain endocrine disorders. Hypothyroidism, low thyroid hormone, can slow down erythropoiesis. Hypopituitarism can mean less growth hormone or androgens, which normally help stimulate red cell production. And finally, while maybe less common as a primary cause of hypoproliferation, severe protein-calorie malnutrition or scurvy, that's vitamin C deficiency, can definitely impair erythropoiesis. They mostly affect cell maturation, but severe cases impact overall production too.
That really ties it all together nicely. The iron studies for ACD versus deficiency, the EPO levels in kidney disease. It shows how the lab results aren't just numbers. They tell a physiological story. So for the MLS, it really is about connecting all these dots, isn't it? From the basic CBC all the way to specialized tests like EPO levels or cytogenetics. This is really where your expertise shines. Let's try to consolidate it. For our medical laboratory scientists listening, what are those absolute must-check, overarching key lab findings you're always looking for when hypoproliferative anemia is on the differential? Let's nail down the definitive diagnostic pathway pieces.
Absolutely. Let's synthesize. Your complete blood count, CBC, is ground zero. You're looking for anemia, low hemoglobin, low hematocrit. The MCV, or the red cell size, is often normocytic, but remember, it can vary. MDS, for instance, often shows macrocytosis, those oval macrocytes we mentioned. So don't rule things out just based on MCV alone initially. Your peripheral blood smear review is absolutely paramount. Morphology is key. Usually normocytic, normochromic in many cases, but be vigilant for those specific abnormalities, the dysplasia in MDS, for example. That's where your eyes make the difference. The reticulocyte count is, as we've stressed, the absolute hallmark. It will be inappropriately low for the degree of anemia. That signals a production problem. It's your key indicator the factory isn't responding. Iron studies are variable, yes, not a direct sign of hypoproliferation itself, but essential for differential diagnosis, ruling out simple iron deficiency, characterizing ACD/AI. You need them for context. Serum erythropoietin, EPO levels, add another layer. They might be low, like in CKD, or potentially normal or even high if the body is screaming for red cells, but the marrow just can't answer the call, like in some PRCA or early AA cases. Understanding that context is key. And finally, the bone marrow examination. It remains essential for a definitive diagnosis in most cases. You need to assess cellularity. Is it empty like an AA, or normal or hypercellular like potentially an MDS? You evaluate maturation, looking for that dysplasia in MDS or the missing erythroid precursors in PRCA. And of course, cytogenetics are vital for MDS classification and prognosis. Plus, special stains and flow cytometry can pick up other specific abnormalities. And just to quickly recap those key terms floating around: hypoproliferative anemia, anemia from decreased RBC production; aplastic anemia, marrow failure, pancytopenia; hypocellular; myelodysplastic syndromes, MDS; clonal disorders, ineffective production, dysplasia; pure red cell aplasia, PRCA; selective loss of red cell precursors. Your reticulocyte count measures new RBC output; bone marrow examination, the direct look inside; erythropoietin, EPO, the stimulating hormone; cytopenia, low cell counts; and dysplasia, abnormal cell development. These are really the building blocks for your investigation.
Wow, what an incredibly thorough deep dive through, the real complexities of these hypoproliferative anemias, from that devastating pancytopenia in aplastic anemia to those subtle but incredibly telling dysplastic features in MDS, and then the very focused destruction of PRCA. It just hammers home how absolutely critical the laboratory findings are at every step. You, as the medical laboratory scientist, you really are the detectives in this story, meticulously piecing together these clues that guide everything that happens next for the patient. It's such a vital role.
It really is. And if we just, pull back for the bigger picture for a second, it highlights something quite profound. While all these conditions share that common thread, low red cell blood production, their actual underlying mechanisms, which specific cell lines get hit, and therefore the distinct patterns you see in the lab, they're all profoundly different. And that really brings up an important closing thought, maybe something for you to ponder back at the bench. How does recognizing these subtle, sometimes very nuanced differences in the lab results not just influence the immediate diagnosis, but the patient's entire long-term journey? Their prognosis, their treatment options, which can range wildly from immunosuppression to stem cell transplant. Keep thinking about how your precise insights, those details you uncover, directly translate into those critical, often life-changing clinical decisions. That connection is where the impact truly lies.